I'm Lisa. I was diagnosed with hepatitis C back in 1990. I was about the age of 20. My family was really worried when I told them. They thought I was going to die within a few years. A specialist told me that as long as my lifestyle was healthy, I would be okay and die of something else. But then he told me about transmission and how I could pass it on to someone else. And I felt dirty and infectious. In 1992, when I gave birth to my daughter, I didn't get that moment where they put her into your arms and you get to say hello. They whisked her off to give her a vitamin K injection into her heel, and I didn't see them use a swab. And had I given my daughter Hep C, I worried. It was a long 2 years of worrying to wait for the test to see whether she was Hep C positive. Thankfully, she wasn't. But I continued to worry that I would pass the virus on to her. When she was a toddler, we were brushing our teeth together, and she asked me why I kept my toothbrush up so high. And I said, "You must never use my toothbrush." And I must have snapped at her because she burst into tears, and she said, "But you're my mum." I felt guilt, I felt shame, I felt upset that I'd upset her. I felt awful that I had, that she had to be worried about a danger from me. I still felt dirty and infectious, and I still worried. When she became a teenager, I told her about the virus and that she must never use my razor, and I explained that she could get the virus too. I also told her not to tell anyone else because I was afraid that she would be exposed to the stigma and discrimination that I'd experienced, even from people that I thought were intelligent, open-minded, genuine friends. She took that on board, but now she worried too about the virus, you know. I reassured her that there would be a cure soon. I couldn't afford to take the treatments that were available back then, as they might have made me too sick to work. But deep down I worried that they wouldn't be available in time. Happily, last year, the new treatments were made available, and I was able to access them in Australia. For decades I lived with Hep C. I lived with the fear and the worry and the dread of discrimination. Now I just live. I'm so happy to be cured of Hep C. Now I just live.
Good day, ladies and gentlemen. Okay, so good day, ladies and gentlemen, once again, and welcome to our first working session. Before we go on, I would just very briefly like to give you some information regarding translation headsets. You all know already probably where to get it, and if you have any queries at all during these 3 days, please do not hesitate to contact staff, which can be recognized by a gray badge. Speaking about first ever global health strategy, we all know that it is divided into 5 strategic directions. It is only if we have good data we can start any activities. And we'll see here and now in these outline sessions good examples what that means to have good data, how to get good data, and most important, how to use good data. So I will not take a lot of your times, and now I will give floor to my co-chair to announce the first speaker.
So our first speaker is Mark Bouteris. He's the team leader of the WHO Global Hepatitis Program, and he's going to talk to us in less than 10 minutes about the global viral hepatitis situation and the response. Over to you, Mark.
Good afternoon, everyone. They say that the hepatitis field is not crowded, but look at the passion and everything that all of you bring to this. It is my distinct honor and pleasure to present on behalf of the Global Hepatitis team. I'll be presenting to you some of the most important findings from the WHO Global Hepatitis Report that was launched at EASL conference in Amsterdam on the 21st of April. Then we will discuss some major opportunities that lie ahead and the critical role of strategic information to focus action towards reaching 2030 targets, as well as some concrete guidance from WHO on what you need to do in country. I think you all know that at the World Health Assembly next year, so in 2018, all countries will be asked to report on progress in viral hepatitis control. So this slide shows you that hepatitis mortality is still increasing every year. Unlike HIV, tuberculosis and malaria, which have been decreasing now for a number of years, the mortality from hepatitis keeps increasing, with an estimated 1.34 million deaths in 2015. 96% of these deaths are due to hepatitis B and C. The remaining 4% is primarily due to outbreaks of hepatitis E. We will not be discussing that in detail here, but there will be a special session tomorrow morning also on hepatitis E outbreaks. So we focus here on hepatitis B and C. Mortality is due to cirrhosis and hepatocellular carcinoma primarily. So the next slide here shows the global strategy on viral hepatitis, and it shows you that the main goal is to eliminate viral hepatitis as a major public health threat by 2030. That gives us 13 years to eliminate hepatitis. So here you see the main goals or targets of the strategy, which is a reduction in incidence of 90% worldwide and a reduction in mortality of 65%. If we look at the status of hepatitis B, then you can see on the right-hand side here the map which shows the cumulated incidence of chronic hepatitis B in children under 5, as represented by the prevalence of hepatitis B surface antigen. This cumulated incidence of chronic hepatitis B in under 5 fell from 4.7% down to 1.3% in 2015. This considerable reduction is attributable to progress in immunization coverage. Nevertheless, we still have some ways to go to increase further the immunization coverage, particularly birth dose. On the graph at the left bottom of the slide, you can see the number of people that are living with hepatitis B in the world. 257 million people estimated, and 68% of these are living in the Africa and the Western Pacific region of the world, the most affected regions. So the next slide shows you the situation for hepatitis C, where we have approximately 1.75 million new infections every year. This is more than the number of persons that were treated in 2015, and slightly more also than the number of people that we believe were cured in 2016. We're getting very close though. Number of people treated versus number of people that are newly infected. So this indicates that the epidemic is still actually increasing. Unsafe healthcare injections and injection drug use are still transmitting hepatitis C in many of the world's hotspots, particularly in the Eastern Mediterranean and the European regions. At the bottom of the slide, you can see the total number of persons that are living with hepatitis C by region. You will note a total of an estimated 71 million persons living with hepatitis C, and the number of persons is about the same in all regions, but there are great variations across countries and of course also across or within countries themselves. If we now look at the HIV and hepatitis co-infection, we see that there is some overlap between the two infections, or between hepatitis and HIV, with approximately a total of 5 million people that are co-infected. Among the 36.7 million people that are living with HIV. Liver diseases are a major cause of morbidity and mortality among those living with HIV and co-infected with viral hepatitis. We at WHO highlight this as a major opportunity for immediate action. These persons should be diagnosed and provided with appropriate and effective treatment for both HIV and hepatitis as a high priority. Then we also highlight here a paper that was published on harm reduction just 1 week ago in the Lancet Global Health. This paper was done in collaboration also with WHO, and it shows you the global prevalence of injecting drug use and some of the characteristics that go along with injecting drug use. Almost all countries worldwide have injecting drug users. It is important to realize that it's not a problem only of a few countries. The estimate of the number of people that are injecting drugs worldwide has actually increased from the last major summary, which was estimated about 12 million. Now the estimate is at 15.6 million people that are actively injecting drugs. Among those persons, 17.8% are HIV positive, and as you can see, over 50%, and in some countries even as high as 90% of those persons are also hepatitis C infected. An additional 9% are hepatitis B surface antigen positive as well. And many of them use opioids, and about a third of the drug users are now also using stimulants, which is becoming more and more common. Close to 60% of the persons who inject drugs also have a history of incarceration. So this also opens opportunities for providing testing and treatment in the prison settings. Data systems are really critical. We have shown you some results from the Global Hepatitis Report, and on every table you will find one of these monitoring and evaluation frameworks, and on 2 pages our colleague, Dr. Yvan Houtin, who sits there, has really summarized all the information that needs to be collected as part of our strategic information framework. Most importantly, we need surveillance for 3 different areas. We need surveillance for acute hepatitis that reflects the new infections that are occurring. We need surveillance of chronic infections, like the information I presented to you earlier. There are still many countries in the world that do not have very good data on the prevalence of chronic hepatitis B and C. And thirdly, we need surveillance also on the sequelae. We focus on cirrhosis and hepatocellular carcinoma, but more and more the recent literature is showing that there are also extrahepatic manifestations of hepatitis, particularly of hepatitis C. So that also needs to be better monitored. Conditions like diabetes and cardiovascular disease have now also been associated with hepatitis C infection. So then the next slide shows you the other page here of this document. It shows you the 10 core indicators along the results chain. This framework was developed about a year ago, and it focuses on prevalence, incidence, and mortality, as well as the cascade of care. Many countries are now developing systems to collect this information for hepatitis. It is available in many countries already for tuberculosis and for HIV. So we need to develop systems together with those other diseases to collect this information also for hepatitis. At the next World Health Assembly, we will be asked to report on the progress with viral hepatitis. So we will be asked specifically to report on these 10 indicators. so we will need information from the countries. Finally, a public health approach needs to deliver to all. That means that certain groups who may be more vulnerable also need to have a very strong and special attention for prevention, care, and treatment services. Civil society in this regard is a very, very important partner, also in identifying and in fighting any stigma associated with hepatitis B and C. We've listed here some of the groups that are particularly or at higher risk of becoming infected with hepatitis B or C. Those are the persons who inject drugs, we already mentioned, healthcare workers also, and in the healthcare settings. Indigenous populations and ethnic minorities in many countries are at higher risk for hepatitis B as well as hepatitis C. Prisoners, migrants, particularly migrants from countries that are at higher risk, and also many who have sex with men, and particularly those who are HIV positive, have a higher risk of becoming infected with hepatitis C. The next slide you have already seen in the presentation by Dr. Gottfried Hirnschall this morning. It shows you where we are currently and the targets that we have to reach by 2030. As you can see, we still have a long way to go with birth dose and with testing and treatment. Particularly those areas need a lot more attention, and also harm reduction for persons who inject drugs. So in conclusion, this is my last slide. In conclusion, the hepatitis B and C epidemics are not yet under control. 325 million people are in need of diagnosis and appropriate treatment. There are still gaps in prevention that need to be urgently closed. And finally, WHO is monitoring the global response. However, some key data are still missing from a number of different countries. We urge you all to further improve strategic information at country and even below the country level, at provincial and local levels. And now we'll focus on actually country profiles with the next speaker. Thank you.
For this excellent overview. And now it's my pleasure to announce Sharon Hutchinson, a professor of epidemiology at Glasgow Caledonian University. She was a member of the organizing committee for the first World Hepatitis Summit, hosted in Glasgow 2 years ago. And Sharon, the floor is yours.
Thank you. Thanks to Tatiana, Leo, and the organisers. Very much appreciate the opportunity to be part of the summit. I'm very excited to be here in Sao Paulo. So I'm going to I'm going to present the latest data we have from governments collected as part of a new WHO-led initiative to establish country profiles on viral hepatitis. And the aim of the country profiles is to determine the status of countries in delivering on the global strategy. And we are very familiar with the targets set on reducing transmission and on reducing mortality. But in order to make progress in achieving those targets, the global strategy also lists a number of priority actions that countries should be considering and taken forward over the short term, over the next year or so. And here I've listed the priority actions under Strategic Direction 1. And so the first set of country profiles have been designed with this in mind, to capture where countries are in their national response, focusing on what plans, policies, and infrastructure are in place. We initiated data collection for the country profiles towards the end of last year. And ministries of health in every WHO member state have been contacted to complete their profile, and I'd like to acknowledge considerable support from WHO regional and country offices in terms of helping us to coordinate and facilitate that process. Myself and colleagues at Glasgow Caledonian University I've really helped to support the team at WHO to establish this new initiative. And interestingly, this initiative stemmed from discussions that took place at the first World Hepatitis Summit in Glasgow. So this slide provides the current status of profiles and where we are in terms of country responses. By the end of September, we had responses from 132 countries, which is near to 70% response rate. We've had a couple more countries coming in since then. But that 132 countries relates to 87% of the population worldwide infected with viral hepatitis. And the map here is coloured according to WHO region, and you can see that we've got the majority of countries responding in all regions, ranging from 54% in the Americas through to 83% in the European region. So I'd like to thank all countries who have participated, and I'd like to urge those who haven't yet responded to complete their profile. And those are the ones highlighted in grey here. There's still a bit of time left to contribute to this important initiative, so please get in touch. I'll give a few more details at the end about that. So I'm now going to give you some of the key findings from the first 132 countries. And as has already been mentioned, we've seen a rise in countries reporting that they have developed a national plan. That's both published and drafted plans. And you've seen the graph on the left already today, and illustrates the rise from 12 countries with a national plan back in 2012 up to 82 countries by 2017. And the 82 countries may well be an underestimate in the context that these are data from 132 countries, so it may well increase from that. And many factors undoubtedly have contributed to the rise at the global level. The Global Strategy 2016 and the first World Hepatitis Summit that preceded that, along with the WHO resolutions, were key milestones in helping to mobilise countries. Now, the 82 countries with national plans equates to 62% of countries responding globally. You see a higher proportion of countries with plans in Eastern Mediterranean, lowest in Southeast Asia, but still 50% of countries with a plan here. And whilst the majority of countries indicate that they have plans, the minority, however, of countries indicate that they have plans with dedicated funding, 35% overall. In every WHO region, less than half of countries reported that they had some dedicating funding. So it is a global feature. The global strategy recognises the important role that civil society has played in getting viral hepatitis onto the global health agenda. And the summit indeed has been formed to provide a forum for civil society and governments to come together to discuss hepatitis. And data from the country profiles indicate that there's now engagement of member states with civil society groups in almost 50% of countries. Globally, just over half of countries report having a strategic and technical advisory group, referred to here as a STAG. Of those STAGs, 56% have said that civil society are a member at that national committee. But there is wider consultation with civil society beyond that of the STAG, and that brings us up to almost half of countries reporting engagements with civil society. What we also observed is striking differences between those countries who had engaged with civil society compared to those who had not engaged. Those countries who had engaged were much more likely to have developed a plan, and also were much more likely to have a national plan which had dedicated funding attached. 51% of those who were engaged with civil society compared to 23% of those who are not. So these data are really testament to the importance of engaging with civil society. The global strategy calls upon countries to set their own national targets. Almost half of countries indicated they had some targets in relation to prevention and treatment of viral hepatitis. Fewer countries had targets on morbidity and mortality, but still a quarter had set targets, and with a further 50% of countries indicated that they planned to set targets by the end of 2017. So clearly, countries are switched on to setting targets. However, the minority of countries had official working estimates and a whole range of indicators on the right-hand part of the slide here. These are indicators that are needed to monitor progress in reaching targets on prevention, treatment, morbidity and mortality for both Hep B and Hep C. And the lack of monitoring and surveillance systems at the country level is a major concern. Without information, it would prove difficult to raise awareness, to advocate for action and resources, and it prove difficult to implement programs most efficiently in order to achieve the greatest target. The global strategy calls for a major increase in diagnosis of chronic Hep B and Hep C. A priority action for countries is to integrate viral hepatitis testing into national policies and guidelines, and indeed the majority of countries reported that they had official guidance on testing. However, these were not necessarily comprehensive, as you can see here, by less than half of countries having official guidance for targeting testing at people who inject drugs. And the percentage of countries with guidance involving people who inject drugs varied quite considerably across WHO region, down to 11% in one of the regions. WHO have published recently guidelines on Hep B and C testing, and this is going to be an important resource for countries to review their policy and develop a strategy on testing in their country. Now, we've seen major advances on the treatment front. For Hep B, we have effective long-term antiviral treatment. For Hep C, we have the development of highly effective, well-tolerated oral DAAs, which has revolutionized the treatment of chronic hepatitis C, although high prices of these medications has been a major barrier in many of their countries. And here's the current status from 132 countries, where these optimal therapies are the first line of treatment for all patients in 59% of countries for Hep B and 37% of countries for hepatitis C. So access to the most effective therapies remains an issue in many countries as at 2017. We hope to see a major shift towards greater access in the near future. So, if I can summarize, we have observed progress in every WHO region in responding to viral hepatitis, with a near five-fold rise in countries developing plans over the last 5 years. Financing, however, remains an issue, with only 35% of countries having developed plans with some dedicated funding attached. We've shown that countries engaged with civil society, which related almost half of the countries that responded here. These countries are more advanced in terms of having developed a plan and having secured funding for viral hepatitis. A majority of countries may well have guidance or national policies on testing, but these are not necessarily comprehensive, nor have they been implemented with any great effect to date, as globally the vast majority of those infected remain undiagnosed. Access to the optimal therapies remains an issue for the majority of the infected population in 2017. We hope to see a change in that as drug prices are negotiated down. Finally, whilst countries are taking on board the action to set targets, these are typically not underpinned by data. Countries have to invest in strategic information systems if we are to have a hope at monitoring progress towards elimination. I'd like to thank all of those who have contributed to the country profile project to date, as many people behind the scenes and WHO regional country offices who have worked hard to get the data presented here today. I'd like to thank my colleagues at WHO headquarters, and particularly Handy for her leadership. I'd like to thank partners at the Alliance for their input from the outset and continued support to establish this initiative. I'd like to acknowledge my colleagues in Glasgow, and a special recognition to Shanley Smith, who's been the one that's coordinated and managed the country profiles. Finally, we thank the Ministries of Health and countries who have already contributed and provided profiles. As I said at the beginning, for those countries that are yet to generate a country profile, there's still a bit of time left. We'd like to hear from you. We'd like to have data collection wrapped up by the end of November. So you need any support with this, please get in touch, either through Shanley, her email address is there, or through your WHO regional and country offices. Thanks very much for your attention.
Thank you, Sharon, for a comprehensive overview. Our next speaker is Charles Go, who is the president of the World Hepatitis Alliance, and he's going to talk to us about the power of people integrating civil society in the global hepatitis response.
Thank you very much, Leo, and I think it would be a bit strange if I thanked the organisers for inviting me, but I would like to thank our partner WHO and our partner and our host here, the government of Brazil. So I'm going to talk to you briefly about a subject that is extremely dear to my heart, about involving civil society and in particular the affected community in the response to viral hepatitis. And I think you saw from Professor Hutchinson's very nice slide on this new data showing that countries that do involve civil society more likely to have plans in place, more likely to have funded plans in place. Now, I don't think from that slide alone you can make a causal relationship there, but I'm going to try and fill in that gap now. I think that civil society has had a major role in viral hepatitis, and I think over the last 10 years from when civil society set up World Hepatitis Day, through working with countries like Brazil on the resolutions, through the World Hepatitis Summit, the first one, the launch of No Hep, we have actually displayed not just involvement in this, but a reasonable degree of leadership. And I think you see that in a number of countries also across the world. We only have these 13 years to take on and achieve this extraordinary goal. Yes, we have 194 countries on board, but the latest data we have says that 9 countries are on track, which is fantastic, but obviously that leaves quite a lot that are not on track yet, because we're starting from such a low base, and the scale up we need is big. We have just done a survey, mostly of our members, 72 countries, 156 responses, and those responses said that 90% of countries had civil society involvement in the hepatitis response at some level. That's the good news. The not so good news is that although almost all the countries and civil society are involved in World Hepatitis Day, 162 countries, only 2/3 of governments celebrated World Hepatitis Day despite adopting a resolution to do so. And very importantly, around stigma and discrimination, 93% of the countries we surveyed reported some level of stigma and discrimination, and only 4% felt that the government was satisfactorily addressing that. And also, 75% had not been consulted about this, and I'll come on to this in a minute. So this is the statement I want to put out to you, that actually elimination targets will not be achieved without the involvement of people who are affected. And what can we contribute directly to this? Well, advocacy is important. Now, I think that in some countries there is perhaps a fear of advocacy, a feeling that advocates just shout at you as the government to get things done. But actually, that may be necessary. That may actually galvanize action. But advocacy can also support what the Ministry of Health is trying to do in terms of raising the priority, but also potentially with resource mobilization. Civil society should not be forgotten in resource mobilization. You know, that has actually been really important in HIV. And of course, awareness. You know, that is something that we still struggle with. Awareness is still low. You walk out to the man in the street, wherever you are in the world, and ask them about hepatitis, and you're much more likely than not to get a very confused answer. And of course, service design. When we're talking about scale up, we're talking about massively expanding services. There is no point spending a lot of resources putting in place services that nobody comes to. And that may be for reasons like stigma. People may not want to come forward for testing if they're then going to find that they're going to lose their job, they're going to be denied education, they're going to be asked to leave the country. So it is really important that people are asked, you know, would you use this service if we set it up like this? Not set up the service and then ask, because it's just a waste of money. And of the global targets, the most challenging one is diagnosis. And it is actually central to the others, because if we do not diagnose people, well, perhaps I put it another way. Every single person who is undiagnosed has the potential to transmit hepatitis B and C. They also have the potential to develop end-stage liver disease and die as a result. So they are really important in the prevention part of this. They're also really important in building the advocacy voice. In HIV, we had this tremendous sense of urgency that drove advocacy. There ought to be that sense of urgency in viral hepatitis with the mortality rate, but we don't have it. But what we certainly have are the numbers. If you had 300 million people demanding action on viral hepatitis, I think we would get it. On top of that, these are the people who can create support networks, who can really push for innovation, and clearly, with those kind of numbers, they can drive down the price of drugs. Even generic manufacturers are completely dependent on volume to lower prices. So if we had the volume, we'll get much, much, much lower prices. Prices are already falling fast, they could fall further. And it's about harnessing these people, identifying them, energizing them, or activating them in the current kind of patient language that is used around activating people who have disease in order to fight stigma, to improve the advocacy, improve the programs, and create this demand. So this is my last slide, and this is a slogan that I think has been used in lots of places. Our NHS in the UK took it on board as their kind of big slogan. No decision about me without me. But it was really taken on as really an ethical statement. Don't do healthcare to me. Let me participate in healthcare as an equal partner with you, the system, the physicians, and so on. But I want to say, in my view, it isn't just ethical sense, it's also economic sense. And as a result, I really want to end by addressing all the governments here. Please do try and involve civil society. There has been in some parts of the world a real reluctance to do that. And I think you are, in a sense, shooting yourself in the foot by not doing it. That we have this enormous possibility of adding to what you're doing, and I would ask you to do that. Thank you very much indeed for your attention.
Thank you very much, Charles, for this inspirational presentation. And now when we heard about the power of people, let's hear about the role of Liver Society in the global viral hepatitis response. And it is my great pleasure to announce Dr. Anna Locke, currently president of American Association for the Study of the Liver Disease.
Thank you very much, and I'd like to thank the WHO and the WHA for inviting me to join you at this very important conference. So when I talk about liver societies, honestly, I don't know how many total liver societies there are in the world, but I know that there are more than 100. And as Charles mentioned, if we mobilize the civil societies, we should also mobilize the liver societies. I will be speaking mostly representing American Association for Study of Liver Diseases, but I'm sure that what I say would also resonate with the other liver societies. And I think that we all can work together in promoting the WHO goals globally. What are the things that we can do? We can advocate for funding. We can provide consultation to WHO as well as the local government, helping develop policies. We can collaborate with the local government, medical societies, the communities to implement the policies. We can certainly do a good job in training physicians and other healthcare providers, nurses, public health staff to empower them to build up the necessary workforce in order to provide quality care. And of course, we still need to do research. We still need to find a cure for hepatitis B, a vaccine to prevent hepatitis C, and at the epidemiological level, we need to have better refined data in terms of the burden of disease in each particular community. And as we try different approaches, we need to understand the comparative effectiveness of all of these approaches. There are 4 major regional societies, the American Liver Association, the European Liver Association, the Latin American Association, as well as the Asian Pacific Liver Association. But within each region, there are other individual countries' liver societies as well. And I'd like to encourage you to join us tomorrow morning at 8 a.m. On the 4th floor in Advocacy, because we have a site meeting of all the 4 regional liver societies, and we'll again talk about how each liver society can contribute to the WHO goals. What are the topics that we'll be talking about? We'll be talking about how we can do a better job in preventing mother-to-child transmission of hepatitis B, both in terms of implementation of vaccination, in particular birth dose vaccination, but also increasing recognition that highly viremic hepatitis B surface antigen positive mothers should receive antiviral therapy. We'll also talk about improving diagnosis, raising awareness, decreasing stigma, and facilitating screening of high-risk populations and how we can integrate that into routine care. We'll talk about improvement of linkage to care, how we reach out to vulnerable populations and persons living in rural areas. We will be discussing about addressing language and cultural barriers, decreasing or removing the financial barriers, and educating patients we've heard at this meeting on the consequences of leaving hepatitis B and hepatitis C untreated and how treatment would benefit them. We'll certainly have to discuss how we can work with local communities and government in improving access to antiviral treatment. Well, let me introduce you to the American Liver Association, the ASLD. We are a very large society. We had our annual meeting just last week. And we are a global society because roughly half of the people who come to our meeting actually comes from all parts of the world. And roughly a quarter of our members are also international members. And our mission is to advance and disseminate the science and practice of hepatology and to improve liver health and quality patient care. So it really fits very well with the WHO goal. And how can we actually help WHO reach the 2030 goals of elimination of hepatitis? We can, well, with ASLD, will be working very closely with CDC to implement the National Academy's recommendation in terms of steps to eliminate hepatitis B and C. We'll work very closely also with Health and Human Services, professional patient societies, and our key roles are really fourfold: advocacy, education, capacity building, and research. In terms of advocacy, we lobby the government. We actually every year go to the Capitol Hill, meet with the senators and the Congress staff, and advocate for funding for support for the NIH, advocate for funding for CDC to implement all the prevention and screening services, and we also advocate for increased control of cost of medications. We actually sponsor and were one of the co-sponsors of the National Academies, which led to the feasibility study that showed that hepatitis B and C can be eliminated, and subsequently a plan in terms of how we implement that. But we are actually better off at doing education, because that's what we do all the time. And we, as well as other liver societies, have a large portfolio of education materials. Many of them can be used by people from all over the world, and a lot of our education materials are actually free, online, available to everyone who has internet access. We have the Fundamentals of Liver Disease program, which was designed primarily for primary healthcare providers. Includes slides and videos with liver learning, which is captured from all our meetings, and it's available to mostly members, as well as some people subscribe to it, with evidence-based practice guidelines on every single topic related to liver diseases, and certainly about hepatitis B, hepatitis C, and liver cancer. They were recently updated, and these are all free. With a number of journals, including clinical liver disease, which is available for free. So, as I've mentioned, many of these materials are online and free to everyone all over the world. We also encourage people to join us as members, because as members you have access to more materials, and for training members, the annual subscription is only $25 a year. We also do a lot of work in training the next generation. So we train hepatology fellows, but we also train physician assistants and nurse practitioners, and we provide funding to support their training. We provide career development for our young physicians through workshops, through training sessions. We provide mentorship. The senior members of our society provide mentoring to young physicians, and this program is available to all our international members as well. But we also try to attract new blood to join our profession by attracting students, residents, and fellows, and we provide a lot of training and travel awards to allow them to come to our meetings and to meet with senior faculty. So as I've mentioned, we provide a lot of young investigators training, and it's not just to the American members. Over the last few years, we've also tried to provide research methodology workshop to train young investigators in association with APASO, the Asian Pacific Liver Association, with the Latin American Liver Association, as well as with the Mexican Liver Association. And we also endorse liver society programs around the world. We provide training travel awards for young investigators to come to our meeting so that they do not need to worry about the cost. This year alone, we provided more than 100 travel awards, and we have travel awards dedicated to people who come from low and middle income countries. So if you don't know how to apply, you can find me and I'll show you how to do it. We also, because we are physicians, we can also help people in different countries to develop care and treatment programs. We can help local governments as well as local physicians to develop training programs and curriculum to help diagnose and treat patients with hepatitis B and C, as well as cirrhosis and liver cancer. We can help you tailor to your local needs and resources. We can help you develop models to treat these patients in accordance with regional and WHO guidelines. We can also help train people to conduct research, collecting local data in terms of figuring out how best to do your job. And we can also sort of discuss and share best practices in terms of lobbying for funding. We have the tools. Oh, I lost my slides. Okay. We have a lot of tools to do our work, but we still need additional tools, and we still need research to find cure for hepatitis B, to a vaccine for hepatitis C. And we have to also work on implementation science to find out what's the most effective way to do the things that we want to do. For the part of ASLD, we advocate for research funding. We disseminate our research fundings through meetings, through journals. We also provide funding to support the conduct of research for young investigators. And we certainly provide platform for sharing of ideas, knowledge, and know-hows. And together with other liver societies around the world and with WHO, with the community, I think we can all accomplish the goals, and we'll be happy to work with everyone. So again, I would like to urge everyone to come to our session tomorrow, and I hope to see some of you again. Thank you.
Thank you so much, Dr. Locke. And now it's time for country-level experience of using strategic information to inform their national hepatitis response. It's my pleasure to announce my co-chair, Leoline Katsizare, who is a consultant gastroenterologist at the University of Zimbabwe in Harare. Leo, the floor is yours.
Thank you, Tatiana. I'm going to talk about the rapid assessments in Zimbabwe. As we know, this session is on strategic information for focused action. And one of the key issues is to be able to generate data in terms of planning going forward. We did carry out a rapid assessment of the state of hepatitis in Zimbabwe in June of this year, and we carried it out over the course of a week. The objectives of the assessment were to look into the current policies and practices across the country, to assess the capacity to test and treat viral hepatitis, assess awareness of viral hepatitis, as well as describe the epidemiological situation in the country. And ultimately, the aim was to formulate recommendations for a viral hepatitis program. So we did this through a desk review of documents, key informant interviews, as well as site visits. And the interviews covered such a lot of people, ranging from government officials, civil society organizations. As we can't make decisions about civil society without civil society. And I actually found that quite helpful. And we also talked to regulatory authorities. We talked to people in private sector, pharmacists, doctors, and so forth. And what we found is that we do have data on the prevalence of hepatitis B, and to a less extent on the prevalence of hepatitis C. We think the prevalence of Hep B in Zimbabwe is around 11%. That of Hep C is less than 1%, but there are questions to be raised about the quality of this data. We don't have as good data on the use of what is the state of patients, of people who inject drugs, because the information is simply not available. There is no structured hepatitis B and C treatment program. Consequently, there is very little data on testing, on the coverage of treatment, as well as on sequelae. But the WHO has told us that about 900 people die annually in Zimbabwe from sequelae of hepatitis B. We also looked at our governance programs and management and awareness, and there are some structures to coordinate viral hepatitis in place. We have a viral hepatitis technical working group, which actually carried out this rapid assessment, and we do have focal persons in place to coordinate the various activities. And we think there is political will and commitment to establish a viral hepatitis program. However, in terms of awareness, there is a bit of fragmentation. There hasn't been, for example, any commemoration of the World Hepatitis Day, and we do not have viral hepatitis specific training within the curriculum, although you'd find that people pick things here and there, and there are no comprehensive information campaigns across the country. In terms of prevention, we have quite a reasonable pre-dose hepatitis B vaccine of up to 87%. Hepatitis B vaccination started in 1995. But interestingly, more than 73% of deaths occur in health facilities, which provides an opportunity for giving a birth dose vaccine, but this is not available. And this is one of the things that I think as a country we need to expedite. In terms of blood and injection safety, we have reasonable national blood transfusion service, and and virtually all the blood that's in Zimbabwe is screened for transmittable infections, including viral hepatitis. There is a large-scale use of disposable syringes. In the last DHS survey, 98% of people reported that they did see the syringe coming out of a new pack. And in the EPI program does use already disabled syringes. But in some respects, there is limited understanding of infection control with hepatitis. You do find that from time to time, some of the healthcare workers actually think that hepatitis actually go on to want to isolate patients who have chronic viral hepatitis, which is a pity. In terms of testing and treatment, we have no guidelines on how to treat and who to test. I think we are going to develop them as we go along. We do have a system in place for HIV and TB, and we can certainly piggyback on these systems. We do not have a national treatment guidelines for hepatitis B as well as Hep C. And in terms of the medications, we don't have single formulation tenofovir. So a lot of the times we treat those patients who are mono-infected with HPV with a combination of tenofovir, emtricitabine, or lamivudine. Single formulation tenofovir is available in private pharmacies, costing about $8 a day, and some patients do manage to get that for themselves. We do not have DAAs available in the public sector, and they are actually not registered in Zimbabwe, but you can procure them on a named person basis and subsequently prescribe them. But we need to move to make sure that that is availed to the populace. We don't have a system for enhanced surveillance of acute hepatitis, and our last comprehensive biomarker survey of hepatitis was in 1989, and I think we need to update that. We know that about 50% of cases of the patients with hepatocellular carcinoma would test positive for hepatitis B surface antigen, and approximately 20% have positive hepatitis C serology. So we have some idea of the proportion of HCC that's attributable to viral hepatitis, but we don't have similar data for cirrhosis. The prevention indicators are available, and we have a national patient database for HIV, which can be adapted for hepatitis B and C. So, in conclusion, what are the strengths of our program? We think that there is good coordination and commitment. There is a solid healthcare provision system, and we have a high proportion of deliveries comparatively in health facilities. Thus, it should be quite simple for us to introduce a birth dose vaccine. the 3-dose coverage for Hep B is quite high, and hepatitis B surface antigen test is widely available, and we have a solid national blood transfusion service. We certainly must come up with a hepatitis program, and we need to get a birth dose in place in terms of what we need to do. So in terms of our recommendations, we recommended that we need a national plan, and this rapid assessment that we did can form the basis of the national plan, and we need good, reasonable, evidence-based policies and guidelines. We need to expedite introduction of the birth dose vaccine. We need to secure access to treatment for hepatitis B, and we need to build up our testing and treatment services, and we need a national strategic information system for hepatitis. And that's a little bit of Zimbabwe. I thank you. I'm going to turn back to being a chair. So our next speaker is from Vietnam. He's going to talk about hepatitis surveillance. It's Tran Dai Quang.
Thank you, Co-Chair. Good afternoon. My name is Trần Đại Quang. I'm from Ministry of Health of Vietnam. My department is General Department of Preventive Medicine, and I'm also the focal person on viral hepatitis national action plan. So firstly, sir, I would say thank you to government of Brazil and WHO and World Hepatitis Alliance to host this summit in Brazil. Honestly, so I'm a big fan of the football, so I'm very excited to be here as a country of five-time winner of FIFA World Cup. And so today, so I on behalf of Vietnam, so I would like to share with you some information on the surveillance system in Vietnam. The first thing, the background on the viral hepatitis epidemic in Vietnam. So in Vietnam, so viral hepatitis still remains a public health problem, especially for Hep B and Hep C. And under reviewing all study conducted in Vietnam on Hep B and Hep C, so we found a huge disease burden of hepatitis B and C infection. The prevalence of hepatitis in chronic infection, hepatitis B were estimated around 9% in general population, and for Hep C, prevalence of anti-HCV is estimated at 1.4% in general population, and it's very high in the high-risk group, like the people IDU and diagnosis patient. And the last year, so with support from WHO and Center of Disease Analysis (CDA), so Ministry of Health conducts a mathematical modeling to estimate the burden of disease for Hep B and Hep C, and the modeling estimated to 7.8 million chronic infection, B infection, Hep B infection, and almost 1 million chronic Hep C infection in Vietnam in this year in 2017. And to compare with the other countries in Asia Pacific region, so the number of cases for chronic infection for Hep B is second highest for Hep B and the third highest for Hep C. So this graph so we take from regional office, WHO regional office, and to respond with the viral hepatitis epidemic in Vietnam. So in 2015, Ministry have issued the National Action Plan, in order to reduce the transmission of viral hepatitis and increase access of people to prevention and treatment service for viral hepatitis. And surveillance system is one of four main solutions in the National Action Plan. And it is an increasing surveillance system to provide evidence for policy development and intervention to reduce transmission in community and healthcare facility. In 2016, WHO have issued the first surveillance guideline for viral hepatitis, and it calls technical consideration and key definition to improve surveillance for hepatitis. And for us, it's quite an important guideline, and it can help us to do the better for outbreak detection, monitor trend in incident, and also the estimate the prevalent and chronic infection, as well as estimate the burden of sequelae of the viral hepatitis. And to follow the guideline of WHO guideline on surveillance, so this activity have been implemented in under the surveillance system in Vietnam. So we focus on the four activities: the key reporting system, sentinel surveillance, serology surveillance, and treatment monitoring. And the first one, let me go through the four activities. The first one, the key reporting system. We do the key reporting system followed by the Circular 54 issued by the Ministry of Health, and we do the key reporting for 42 infectious disease and hepatitis. We divide to three groups: hepatitis A, B, C. Under group B, it means each individual case of hepatitis must be reported no later than 48 hours. And we require our own health facility from commune level upward to the central level need to involve to the system, and all facility have to provide the account to directly go to the online system to report case base for each disease. And that's a reason until now. So in 2007 so far. So hepatitis B. So we get in 2000 we got 17,000 case base of Hep B, and for Hep C we got over 2,000 patients, and Hep A, so we got over 250 patients for Hep A. The second activity under the surveillance system is a sentinel surveillance. So we do the sentinel surveillance in order to monitor all consecutive patients who have a diagnosis of acute and chronic viral hepatitis and sequelae. And we in 2017, so we do we do sentinel surveillance in one sentinel site in the National Hospital of Tropical Disease, and in next year 2018, so we propose to extend to three more central hospitals. And the interim result from sentinel surveillance in 2017 so far, so we screened almost 1,000 patients, 956, and in weeks we found 142 patients with Hep B and Hep C infection, chronic infection. And in this chronic infection patients, so we analyze by the age group, by the gender, by the fibro scanning, also by some alcohol behavior, and also some risks of exposure like inject drug user or transfusion. For the first one, so in collaboration with the CDC, so we do serology surveillance in order to estimate the prevalence of hepatitis B and C infection among the adult population in community. We also expect this surveillance to identify the factors associated with happy and healthy infection in surveyed population, and also access the knowledge of the surveyed population. So for this surveillance, so we conduct the cross-sectional household survey, and we do half of the country, 32 provinces, and the sample size for this surveillance around 26,000 people. This surveillance, so we have been implemented by end of this year, December this year. And in this surveillance, so we also do both of serology testing and molecular testing. So in first stage, we do the serology testing, and on positive sample will be stored for phase 2 testing. This one is for progress of the serology surveillance. The first one for the monitoring Hep B and Hep C, now so we still under discussion with WHO, and we expect to conduct the first one in next year. So my conclusion for my presentation is that generation national data on viral hepatitis is critical and very important. It expects to help us to understand for viral hepatitis epidemic in the country, and understand how viral hepatitis are transmitted in the country to inform the public health action for prevention, and also the understanding the disease state and accept to early diagnosis of Hep B and Hep C patients. And last one is expect to monitoring access to treatment and progression towards the elimination targets. So thank you for the attention.
Thank you, Tran. Our next speaker is Dr. Imanda Klan. He's the Secretary of the Directorate of Disease Prevention and Control in the Ministry of Health of Indonesia. He's going to talk to us about their country-level experience.
Thank you, Coach Chairman. Good afternoon, distinguished participants, ladies and gentlemen. It is a great pleasure to talk in this very important summit, which attended by all representatives for all over the world. And I'm proud to share with you that since WHA Resolution 63.18 in 2010 adopted to National Action Plan, Indonesia make efforts to control and prevent viral hepatitis by strengthened foundational indicator and surveillance system, as well as founding mechanism for analysis and or diagnostic that are able to demonstrate of significant responses in viral hepatitis elimination. One of the effort is estimating viral hepatitis core indicators to assess current hepatitis situation, trends, and its national responses. Ladies and gentlemen, Indonesia is the largest archipelago countries of the world, which consists of 5 big islands and more than 17,000 islands with total area around 5.1 million kilometers, and the number of people is about 263 millions, which are living in 34 provinces. Around 2,000 hospitals and 9,000 public health centers are built to serve the people of Indonesia. Indonesia is under the region with moderate high endemic of hepatitis B and hepatitis C. The prevalence of the hepatitis B is 7%, 7.1% in adults and 4.2% in children under 5 years old. To bring down the prevalence of hepatitis B, 159 districts carry out early detection of hepatitis B, and nowadays we start the project of direct acting antivirals in 28 hospitals in 6 provinces. Indonesia is working toward elimination of viral hepatitis as a public health threat. We did many activities and developed national policies on viral hepatitis control program used as the basic programmatic tools endorsed in 2015. Ministry of Health Regulation number 53 on 2015, which is focused on several activities including hepatitis B, early detection during antenatal care for preventing mother-to-child transmission, hepatitis C screening among high-risk program, and providing access for hepatitis C diagnostic and treatment, including for people who inject drugs and people living with HIV. This year we collaborate with WHO to review baseline situation with 10 core indicators by analyzing the situation of viral hepatitis in Indonesia through the framework of the baseline value, extracting the data from possible data source, engaging the stakeholders to share data on our information, and initiating work to estimate the cost effectiveness of treatment of HCV infection with direct acting antivirals from a healthcare perspective using WHO online hepatitis C cost effectiveness guidelines. These are the 10 core indicators which are using to assess current hepatitis situation, trends, and its national responses. With these activities, we will plan the appropriate and efficient approach to achieve the target programs. The work on the core indicators is in progress and will be updated on the basis of the feedback received from stakeholders. Data was collected and extracted in quantitative and qualitative methods since July 2017 in relation with completing the profile of Indonesia in terms of the 10 core indicators, secure in the inclusion of HBV and HCV in the next iteration of the National Health Survey for 2018 to more trends of incidence. The implementation strategies are conducted by integration with existing health priority programs such as mother and child health programs through a family approach with outreach activities, early detection during ANC and newborn care, harm reduction, HIV and TB programs, immunization, patient safety, blood safety and public health insurance, and mutual partnership and strong collaboration with NIHRD, WHO, professional organization, CHAI, PKNI, Red Cross, universities are one of the success keys in implementation. Integration of 3 programs called elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B as innovative breakthrough is in recognition of Indonesians' ongoing initiative and consistent support in the area of viral hepatitis. We hope that with the public health action as current resource, we can achieve our goals. Finally, let me conclude my presentation by asking all stakeholders to take the real action to eliminate viral hepatitis in the world, and thank you very much for your kind attention. Obrigado.
Thank you, Dr. Dahlan. And now we are opening a Q&A session. So, any questions from the audience? The micros are in the middle of the tables. Maybe I can start with the one question to the panelists. So, as a civil society representative, I'm very interested. How can NGO get and have access to the data that is needed to make plannings in country and to convince the government? I want to know how I can get access to latest accurate data out of my country, and which are the key reliable sources I can use that are accepted by governmental affairs. This is a very important question for me as a civil society representative, and also for the civil society representatives here in the room. So, anyone would like to answer? Sharon?
I think what's been highlighted earlier is the importance of having, for governments to have civil society plugged into their national committees, their strategic and technical advisory groups. I think it's not just a message of integrating civil society into that top-tier government group. It's a message for all of us to integrate civil society in all of the groups that are planning prevention services, the groups that are planning diagnosis and treatment services, the groups that are planning the strategic information systems. And I think it's important for civil society to be at the table and plugged into all of these groups, and we can learn from each other. And that is one way in which you could get access to those data.
Okay, thank you. Any question? Or you are already tired? Yes, there is one question.
Thank you, Sharon, for the very nice presentation. My question is, in any of those national strategies, there are data of care of children with viral hepatitis?
Sorry, say again, strategies.
So you collected data on national strategies and implementation, but any of those including care for children and adolescents with viral hepatitis? I don't think it's in any strategy globally, and I think we need to do this.
Yes, these two.
The country profiles were a first attempt at this, at getting information from countries. So we are getting the top tier of information on that. We have asked about further details for those national plans so that we'd be able to access them and look at things like that, but I don't have any information that gives the detail of what's contained within each of those national plans. But I note your point, and I think it's an important one that countries need to be addressing children as well.
I think Mark should answer this question as well.
Thank you. Thank you, Dr. Manal. As you know, we are including a chapter, a quite extensive chapter now, on pediatrics and adolescents for the new hepatitis C guidelines. So we certainly feel it is a very important area, and countries should include more data in their plans, particularly to address, I think, the issue of hepatitis B and C in children and adolescents. So thank you.
Yes, there is one question. Yeah. Yes, please.
with the U.S. Centers for Disease Control and Prevention. Thank you for this very informative session from everyone. I have a question for Indonesia. I know Indonesia was one of the first countries that introduced the hepatitis B vaccine and also the hepatitis B birth dose. And you specifically use also UNIJECT to reach the home birth. Within your strategy, use the birth dose within 7 days instead of 24 hours. I've seen in your slides, you've estimated the prevalence in children under 5 to around 4%. But I believe that was an old survey and it was in one particular state. I think if you do another survey now, you'll definitely have a lower prevalence in children. So I know in Indonesia you do a regular surveys in the population, so testing these specimens for hepatitis B would give you a better information on your current situation. Thank you.
Thank you very much for your question. I agree with your statement that survey is big trouble in Indonesia right now. So we have to have another survey for the number of the hepatitis B for infant under 5 years. Thank you very much.
So I've one comment in response to the question that Tatiana asked, which is how can we share information? So in many countries, data collected by the government is available to the public. For example, in the US, data from CDC as well as from NHANES can be available. But there's a lot of other data collected by the community. Unfortunately, sometimes it's difficult to integrate them because they use different definitions. And one of the things that we really need to work on is how do we define the data collection? And I'm very happy that Sharon actually shared some of that. Because unless the data is defined the same way and collected the same way, even if you manage to get them all together, you cannot piece them together. And if we can all sort of agree and use that. Because there are a lot of, for example, screening programs done by the community. There are also stigma programs, stigma surveys. Actually, at this meeting 2 hours ago, I got an email from someone in the Netherlands because they realized that we published a paper on stigma and hepatitis B in China. And they asked us for a copy of the survey so that they can use the same survey in their studies in Europe. So I think that we all need to be willing to share, but we also need to figure out how we can standardize some things.
Thank you. Yes, please.
So thanks to the chairs and the speakers, it's been a really informative and interesting session. My question is for Dr. Tran. I know Vietnam has spent a lot of time and effort improving the surveillance system and shifting it to a web-based format and has done some really innovative work using linkage with common indicators across the health system. My question is, what do you think the capture of diagnosis is using rapid tests? Because I know in Vietnam, as in many countries, particularly for hepatitis B, a lot of screening is using point-of-care testing. What is your feeling about the incorporation of diagnoses made through rapid testing into your surveillance system?
Thank you for the question. So actually, so the proposal also, we also under discussion on that because of in Vietnam, so now so we apply for birth dose and birth dose for all children, all the newborn after the 24 hour, and also we do screening. We also do the screening Hep B for all pregnant women who registration for in the hospital, and that's the idea. So we propose for in specific activity in our revised national action plan, but the challenge for us now is the funding, and we still working with the state government and also for state budgets and also the donor for support us to do that. But we also review, we also have a literature review from other neighbor countries like Thailand, and have a good experience on that. So we propose for update and revise the national action plan.
I think we are only going to take one more question.
If it is burning.
Hi, my name is Sue Wong. I'm from the US, and I am both a patient and a physician, and also on the board of the Alliance. And Charles, thank you for reminding us how important it is to include the patients in everything we're doing here. And I think that's happening in the world on various levels. And here we have in this room both ministers of health, people in the government, and a lot of community members and patients. Is there anything in the action plans that requires governments to work with the patients? What we hear a lot in the community is that they have a difficult time accessing the government members. And so how do we connect the two? And is there something in the action plan that where we're monitoring how governments are including patients and communities?
Well, I think just to chip in from a global level, the WHO country profiles are monitoring that. It is it's certainly referenced within the global strategy, the importance of including civil society, and we are monitoring that with governments to see to what extent they are engaged with civil society. So that is one way to kind of highlight that.
Thanks for your question, Sue. I think that, as you know, the last resolution in 2014, the third clause asked countries to make sure that they included civil society in national action plans. But one of the ways, as well as monitoring it on a consistent basis, is asking WHO to help with this. So WHO are often involved providing technical support to countries in the development of their national plan. And that is a real opportunity for WHO to insist on the inclusion of civil society within those plans. And I think that is something that WHO have taken on board and are moving to do that. And obviously, the summit is an environment in which civil society can talk to both WHO and program managers and ministers to really encourage them to do this. So I think it's something we're definitely seeing a shift in, but we're not there yet in terms of the amount of involvement that we'd like to see.
If I might just ask Hande if she maybe could stand up, Dr. Hande Harmanse. She is the person who is reviewing all of the national plans at WHO, and this is definitely a very important factor also that we take into account.
I think it's left for us to thank our speakers for giving such illuminating talks. We have 2 announcements to make. This year's event includes 9 side meetings and 4 sessions of oral presentations from abstract authors. You are urged to take advantage of these extra sessions, and which are really organized by global experts. They are open to everyone. You do not need to register, and the details are available online or on the event app. And there are evaluation forms which will be emailed to you electronically at the end of the event. Please fill in these. They help in planning future events. And I must add, if you don't, we know where you live.
Yes, and the last announcement is about dinner tonight, gala dinner, which we will have at 8 p.m. in this very room. So at 8 p.m. We will meet you for the dinner, and thank you once again, and thanks to the speakers.